Thanks, Peter. Yes, I'm here. Hopefully you can all see me. I will just briefly say hello with a face to the name for those of you who I haven't met. Introduce myself. I'm Sharath Srinivasan. I'm a senior advisor now at Africa's Voices Foundation and also co-founder and presenting this work on behalf of the team who I'll introduce in a moment. I'll now go off video and share my screen so that we can follow the presentation on the screen. So I trust everyone can see this presentation now. Okay, so I will kick off straight away. So this is a presentation of what we've called a rapid diagnostic, consulting with a large number of Somalis in South Central and Puntland on their views on coronavirus just 10 days ago, or just thereabouts, over this short space of a weekend. And then we've turned this analysis around and presented some findings late last week to one group and now to this group here. So as Peter has said, very eager to open this up to a discussion on implications and actions and where this work can go next. A few introductory notes. I want to just give acknowledgement to the teams that have been involved in this work. On the Africa's Voices side, it's a team on the Diagnostic with Samatar Abdi, Zakaria Sheikh, Nazra Ali, Isaac Mwenda, Anna Colum, Lucas Muller, and Luke Church. And then we obtained really valuable feedback from Peter Haley, Nancy Balfour from Center for Humanitarian Change, as well as colleagues Guhad Muhammad Adan, Khalif Abdulrahman, and Dan Maxwell at Tufts. So just want to say that this is a discussion between a number of us on what sorts of implications are coming out, as well as with others, and we've really benefited from the input of others on this thus far. I also quickly will acknowledge that the work sits within a program that I'll introduce now that Africa's Voices has been conducting for the last year, supported by the Somalia Stability Fund. And then the research specifically here also got some support from the University of Cambridge, the Al Barada Fund that is part of the Cambridge Africa Initiative. So without further ado, I'll get started on this presentation of our findings from this diagnostic. Sorry, there we go. Yeah, so as I mentioned, this sits within a wider program of work, and it was made possible because of that program. That program is called IMACAL, and it's a program using a range of different media interventions to further gender equality and social inclusion in Somalia, focused on South Central and Puntland. And the program has as its approach to really involve the voices of citizens in the shaping and designing and even content of the media production, so that social and norm change is happening with and through their voices. So I introduced that only to give context to the fact that we've been hearing from a range of Somalis over a period of a year that's driving this conversation on gender equality and social inclusion. And now, because that is a trusted channel and space of engagement around sensitive issues, we're seeking to pivot that to focus more closely and sharply on some of the dynamics around COVID-19. So with that platform, we were able to send out a question to the participants in this program over the last year, those who had sent in SMS to a free short code over the year, which numbered over 50,000 Somalis. And we thought, well, why don't we ask this group? Many of them are very active, not all of them have stayed active throughout the year. A broad question on what thoughts were on COVID-19 and on coronavirus. And you can see that question there on the left of the screen. So a really open question that allowed for any and all thoughts really to come back to us. We heard from over 7,700 Somalis. That was a response rate of around 15%, sent in a very large number of SMS, all in open free text written in Somali. And of those, 7,120 opted in giving consent to this analysis. And we analyzed over 15,000 messages. What we also did is where people raised questions or there was a particularly sensitive statement that was worthy of a response, we designed a response protocol that responded to that proportion of the respondents. Now, as I said, these questions were asked on the 3rd and 5th of April. And then since then, we wanted to also see how quickly could we turn around that kind of rich SMS data in an analysis and produce the results that could be timely and relevant to responders. And that's the process we followed to get to today. So because of the nature of this consultation, those who we heard from selected themselves. And so we have a skewed audience here within South Central and Puntland. It's skewed towards urban populations, the displaced populations or recently displaced as self-identifying, and also younger populations. Yet, of course, in the context of COVID-19, these are populations of concern. So we're thinking especially that what insights we do glean from this group is of a group that is of interest to a range of different responders to the crisis as it unfolds. And here you get a picture of the demographics of who we heard from. The participants by region skews towards Banadir, Galmudug, and Hirschevelle, but as well Southwest State. The gender profile is 60-40, roughly speaking, but as you'll see below, that is different across age ranges. So for younger age ranges, it's quite fair parity, especially for 15 to 17-year-olds. Thereafter, the gender split weighs heavily towards males. Of importance and interest is the fact that we hear from a large proportion of those who identify as displaced, recently displaced, as a question that we ask, and that's about 40% of the sample that the analysis you'll see now. So what are Somalis thinking about COVID-19? Here are just 4 voices that I want to introduce to give a sense of the kinds of perspectives we heard. The first in the top left is an expression that was very prominent. My thought is that I'm trusting in God, I'm trusting in Allah, and I'm hoping that these difficulties will pass. And this also was complemented often by a reference to religious practice. In the top right, we see a contrasting picture, which is that this disease is dangerous, its cure is only prevention. Therefore, if people follow the information given by the government, I think it wouldn't have spread, and it is spreading now, thanks. So very much a clear call to practice. In the bottom right, we see a message that is on the sharp end of many that we received, that the prevention is to expel non-believers from Somalia, and of a very clear identification of COVID-19 with outsiders. And finally, in the bottom left, a message that speaks to a range of ways in which people are interpreting and understanding the cause of coronavirus as well as its treatment. A mixture here, in this particular case, of traditional medicines as such for traditional or common ailments, and then a reference to prayer and to God, and then also a reference to proper hygiene. Now, that kind of combination was not uncommon as well. So I present these because they're very relevant to what we found in our analysis at an aggregate level of the types of voices we were hearing from. So here are some headline findings that I will go into in a bit more detail. The first is that asked for their thoughts on COVID-19, Somali respondents spoke less from a health than from a religious hope or practice standpoint. And this was a centrally important finding that breaks down in important ways. The second was that respondents fall into 2 broad camps: those invoking religious hope, practice, or guidance as the right way forward. Nearly 40% of those who we heard from mentioned that in one or more of their comments, or those invoking community action aligned to expert or government advice with a call for right practice. This was more around 35%. The religion frame grows more salient with increasing age, and it splits evenly between a sort of passive faith, hope, or trust framing of thought to more active focus on devoutness, on prayer, and on offering. Younger age groups, notably females, are more likely to advocate for following expert government advice on right practices. And these are tendencies. These are not sort of black and white, but they're important tendencies we saw in the data. The fifth headline finding is that over 1 in 10 respondents expressed thoughts on COVID-19 that involved rumor, stigma, or misinformation, so over 12%. And over 75% of these respondents expressed negative stigma, so hostility, anger, or resentment. I'll go into this in further detail shortly. A message denying coronavirus was over twice more likely to come from a male than a female. Although these messages were not that common, it also speaks to a tendency around a resentment and negativity and disaffection. The sixth finding is that recently displaced were significantly more likely to express such thoughts than those who were not. In Benadir, recently displaced were twice more likely than host community respondents to express rumor, stigma, or misinformation. This was also more likely, and point number 7, to come from respondents from Bay and Lower Juba than from Benadir. So there's certainly a strong line here towards particular parts of the country where we heard this more. Finally, respondents from Puntland were significantly more likely to speak about factual aspects of coronavirus and less likely to speak about religion compared to those from Benadir as a sort of contrasting picture. So these are the main findings, and I will repeat them and go into a bit more detail in what follows now. So here is the pyramid as such of the kinds of things we heard, and you see at the bottom and the base of the pyramid the foundational 2 dominant themes around right practice and for religious hope and practice. And so we see respondents divide into these 2 main worldviews, one with a trust in God and godliness, another with a trust in expert advice and authority. And these are indeed overlapping, as I said in one of the messages earlier, and it's important to emphasize that. But importantly, both have a strong collective we dimension in the expression that people were using, very much referring to what we should do or what Somalis should do, what Muslims should do. And that we, for us, was quite distinctive, more than what we've seen, for example, in Kenya, and is an important signifier for how programming can move forward. Rumor, stigma, and misinformation is substantial. Again, much more substantial than we've seen so far in our work in Kenya. And I think interestingly, and again in contrast to our work in Kenya, much less of a focus on cause, on symptoms, and on spread. So questions or thoughts about the specifics of the virus at this point, and much less on the socioeconomic impacts that we thought we would get, perhaps also because this is early on at the moment in the crisis. So just to unpack those 3 big themes at the bottom, right practice, the call for right practice, rumor, stigma, and misinformation, and religious hope and practice. We broke this down and looked more closely at what the messages contained. The calls for right practice were largely a call for a general call for following advice of government, of experts. Although there was also a breakdown into specific calls around hygiene and distancing or isolation, as well as references to multiple practices. And this differed also amongst demographic groups somewhat. As far as rumor and stigma and misinformation was concerned, as I said, a very large proportion, nearly 75%, was really stigma or hostility or anger. And so that strong negative stigma was expressed in various ways, but predominantly around the distinction between Somalis and Muslims and outsiders. And this often tips into the expression of denial that the virus will affect Somalis or affect them. And I think, quite clearly public health messaging and restrictions around movement, etc., enter into this fray with this kind of context, and that's something we want to pick up. Finally, you can see with religious hope and practice how the split between hope and fate and between practice itself was quite even. So if we dig a bit deeper into this, we find that rumor, stigma, and misinformation were more prevalent in more insecure areas and amongst displaced communities. So we were able to run some statistical analysis, regression, multinomial regression, looking at the kinds of effects that are seen when holding other variables constant. And here we got some clear results. One of them in the gray box there was that IDPs are significantly more likely to send one of these messages indicating stigma or misinformation than members of host communities. And that was especially so in Mogadishu, where recently displaced were twice more likely to mention these kinds of messages. Again, going back to the fact that most of these messages are around negative stigma, points to a clear area of concern. It was also statistically true that people in Southwest State were more likely to mention this kind of thoughts than compared to Banadir and other regions. The takeaway from this for us was that there's a compounding effect going on here. We know that those in unstable regions or in displaced camps are, as with the population as a whole, but especially so, unlikely to be able to access the kind of health services that will be important in terms of treatment and management of the virus. Prevention thus becomes crucially important, and prevention turns heavily on the ability to provide trusted information that people act upon. Now, the problem in these contexts, of course, is that trusted information sources are competed over. And so the very priority of response is compromised by the increased level of distrust and indeed misinformation and stigma that persists in these communities. This isn't something we'd like to take forward in terms of recommendations, and as we discuss this further. Here you'll see some, here you'll see just some of the visceral expressions of hostility and anger and resentment. These are just a small selection, but I will leave you to look at them freely. The religious lens has a sharp tip to it. So where for the vast majority of people we heard about devoutness, faith and trust in God and prayer as the predominant frame through which people were thinking about and experiencing this crisis, the sharp tip of that is a rejection, a hostility, and a resentment and anger. And it very much focuses on the other. And the other can include, and primarily does include, non-believers. But it also includes so-called doctors, as you see in the bottom center quote, and those who are purporting to save people from corona. And it also includes in the quote on the right, the government as well. Seeking to make money out of this, putting repressive measures in place like on mosques, and also, of course, the diaspora. So the other becomes very, very important in some of the sharp end of this understanding of the virus through a religious lens. There were less messages that focused on the cause and in a way that was misunderstanding the cause of the virus or on treatment. They were there, however, and they focused especially on analogizing this with the common cold and treatments for the common cold. Dengue fever and measles came up a fair few times as well, and treatments that related to sort of common treatments for ailments. Alone, these are not major issues. They do need to be dealt with. They obviously are more of a risk when they stand in the way of the practices that are required to prevent. Moving to the focus on religion and right practice and some contrasts that we saw here. We found that religion was a frame that became more salient with age as we looked at the respondents, and right practice was one that was more salient for younger populations. Now, this is not a massive difference, but it's significant enough to point to opportunities to target and tailor communications more effectively depending on target groups of interest. And that does point to sort of clear opportunities, and we'll come to that in a second, where how to ensure that existing trusted sources of information and authority feature prominently as messengers and as interpreters of messages around prevention, and that we think is crucial. The call for right practice as well, just to say, speaks to something we hear of quite a lot in many of our programs, and that is a real appeal to community solidarity and collective action that comes especially from young people who often express very strongly this desire to take charge and to take ownership and act together. So here we see just a few of the quotes around religious hope and practice, which just reinforces things that we know, many of us know very well. But just to recall, this was an open question about what are your thoughts on coronavirus, and it was so prominent, it was so strong. How much we heard back was first and foremost to see this through the lens of religion and religious practice, and that can't be emphasized enough. Because it was just so striking compared to anything else we've seen, especially in Kenya. The call for right practice here, a selection of messages on purpose, many of them from younger women, because there was certainly a tendency for younger people, but also in particular younger women, to be calling for right practice, to be talking about following the advice of government or experts, to be talking about specific practices around avoiding going to public places, etc. And so I think what we saw is this real willingness, interest, and desire, especially tilting towards younger people, but not only, to be seen to be acting in the right way, to see their community acting in the right way, to be following practices, and thus potentially as valuable influences. So at this point, I'll just wrap up with a few thoughts on what we are seeing and thinking that a COVID-19 risk communications and community engagement response needs to do in Somalia. I've grouped them into 3 lots. The first lot is these 3. Obviously, we think it's super important to work with and through religion as the dominant community framing of COVID-19 at this point, and the trusted source of authority, but also the key source of risk. And that involves especially trying to mitigate significant stigma, notably hostility and anger towards the virus itself, but also towards outsiders, non-believers, and potential harbingers, or those who are seeking to make benefit from this. And there's a need to anticipate that this kind of rumor, stigma, and misinformation is compounded amongst IDPs and conflict-affected communities, that this is a harder battle and yet more important in these contexts. And I just put some bullet points under there that are trying to reinforce this in as blunt a way as I think we can say at this point. Obviously, any programming around this virus enters into a dominant Somali religious worldview. Programming must work with and through trusted sources of authority, guidance, and reassurance in times of crisis, and especially in times of crisis. They will be the primary sources of guidance for people. If it does not, worse, if it's at loggerheads with this worldview, it's liable to fail or backfire. And I think understanding then what is the messaging that is coming out of these other sources of trusted authority, what is being said at the moment, and how is it being, how is this virus being translated and interpreted by those who have authority, is crucial as a starting point. There's no tabula rasa here. A public health first framing seems to imply that it's entering into a vacuum, but actually there is not one at all, and it's very much the primary influences that need to be understood first, and then public health dimensions need to be brought within them. There are also then sensitivities around curtailing religious gatherings that need to be thought about, and this is especially as concerns the government, because they need to be anticipated and addressed, especially given Ramadan coming soon. And I think that points to something more challenging, which is that where authorities or agencies bypass the primacy of religious authority, others are liable to step in, instrumentalizing what already exists, which is a hostility and anger and resentment. Now, this is especially a concern with vulnerable groups in areas like Bay and Lower Juba and Banadir, but certainly within South Central, there is this risk. So there is already a baseline that can be instrumentalized, a baseline of hostility and resentment that can be instrumentalized by those who seek to show that those who are responding to the virus are following a foreign outsiders tune. And that is a real risk. The second group of suggested ways forward is to leverage this strong community solidarity around right practice, especially amongst youth and notably female youth. And also tackling rumor and misinformation around the virus source and treatment. So bringing together this, this opportunity to leverage a desire to advance better knowledge, better understanding, better practice from a public health perspective that exists within a large proportion of those who we heard from. And I think we just would emphasize here that this chimes a lot with our past work, as I said, a strong collective we element that is real opportunity to leverage this agency and this desire to be seen, to be acting together that exists within the Somali community very strongly. Frames, for example, that see women as the backbone of society or youth as the pillar of society should be leveraged to galvanize influences for a collective response. And this point about causes and treatment, that alone they're not necessarily alarming, but they do need to be addressed, and they can be a source of a barrier to effective response. Very finally, I think for us, we're very clear that the approach to content, to communications content and messaging, to media and communications channels really does need to be done very thoughtfully and very empathetically, especially in the context of a crisis. Being able to use trusted channels and platforms and ways of, and also messengers is very crucial to having an effective message carried through. And finally, very finally, I think we feel that this is a snapshot of a view 10, 14 days ago that's already certainly changed by now and is liable to change quite considerably in the days and weeks and months ahead. So how can we retain this ability to listen, to hear what's happening, to keep listening, and then to act, to make sure that we're making sense of this epidemic through Somali worldviews in order to drive action, which we think is essential. Peter, I might leave it there. I suspect I've gone a little bit over time, but I do have some comments on what we are hoping or planning to do next. I could just end with those, if you'd allow me.
Yeah, go ahead.
Okay. Yeah, so I guess just from our side, just to sort of say where we're at, and I think this will come up again in the discussion ahead, we're eager to be disseminating these thoughts and discussing them actually, and actually thinking about them with others like on this call. And also we have developed some visualizations that allow us and then hopefully others to interact with the data that we're just in the process of finalizing. Just to give you a very quick sense of what this looks like and what we're hoping to be able to do, I will need to escape from here. And I think you can hopefully see that now. Can you see this? Check, Peter.
Yes, we can see it.
Okay, so I mean, what we've just done is brought this data into comparisons that are visual to allow us to actually explore it and others to explore it more effectively. So here we're looking at the different themes we found and whether the difference between displaced and not displaced people in Banadir, and seeing if we see anything of interest in terms of the different themes we heard and distinctions. So for example, the call for right practice is something that's when we normalize this data is more prominent amongst not displaced than it is amongst displaced. And that's of interest. What's perhaps even more of interest is that the call for right practice, when it's normalized, displaced are referring to in a general sense. We should follow advice, we should follow authorities, we should follow the experts. More specific references to practices appear to be more salient amongst those who are not displaced. So around distancing or isolation, around hygiene, or references to multiple practices. So more specific knowledge on prevention practices appears to be more prominent amongst not displaced than amongst displaced from who we heard. And we also see this distinction around stigma and hostility and rejection, a more prominent amongst displaced in red than it is amongst non-displaced. And similarly, just here is a contrast here. I'll just get to the top of how all the messages around all of the things we heard about versus specifically looking at stigma, hostility, rejection, and anger. And when we look at this in terms of a map, this is still in progress, but what we see here is in Bay, for example, messages from Bay made up 3.8% of all of the messages on themes that we have in this analysis, but it made up 6% of the messages expressing stigma and hostility and anger. In Lower Juba, it was 2.2 versus 5.7, so again, a substantially different level. And it's with that we start to see, not just through the statistical analysis, but through this, some of the patterns that are of interest to us. So I will leave that part of it there, and just say that what we're hoping to do is also to pick this up in further consultations with people we're heard from or other groups using this SMS approach primarily. And I think there's opportunities here to think about not just what the general thoughts are, but also more specific questions around trusted sources of information, around changes in socioeconomic conditions, around coping strategies and responses, and also around community level detection of symptoms, etc. I will stop there and open things up and come back to some of this later, perhaps. Thanks, Peter.